Hello crystals, welcome back to my channel. Today we are going to know the detailed explanation about Tetralogy of Fallot, means its detailed basics, fetal circulation, etc. So without wasting our time, let's get started. Firstly, we have to know about the normal adult circulation. So you can get the proper idea about fetal circulation, means what is the difference between two of them. So as we know, our adult heart have four chambers, namely right atrium, right ventricle, left atrium and the left ventricle. So between these chambers there are valves are present. So between the right atrium and the right ventricle, tricuspid valve is present, and between the left atrium and the left ventricle, bicuspid valve is present. There are also semilunar valves are present. So between the left ventricle and the aorta, there is an aortic valve is present, and the pulmonary valve is present between the right ventricle and the pulmonary artery. There is also superior and the inferior vena cava that collects the blood from the upper and the lower halves of the body respectively, and a aorta that takes the blood from the heart and sends it to the various parts of the body. Here is the actual image of our heart. As you can see, our right atrium, ventricles and the valves and the superior and inferior vena cava and also the pericardium, which is our covering of our heart. Now briefly revise our circulation. So the superior and the inferior vena cava collects the deoxygenated blood from the body and then into the right atrium. Then this blood goes into the right ventricle through the opening of the tricuspid valve. Then as the pulmonary valve opens, this blood goes into the lungs for the oxygenation through the opening of our pulmonary valve. Now this blood, the oxygenated blood from the lungs comes into the left atrium through the pulmonary vein. Then the bicuspid valve is opened and then it transfers into the left ventricle. Then blood is pumped out into the aorta through the opening of our aortic valve, and the oxygenated blood is distributed into our whole of the body. I hope you get it. Now let's talk about the fetal circulation. So as the fetal circulation is different from that of the adults because of the presence of placenta. Fetal lungs are not functioning, therefore blood needs to bypass the pulmonary circuit, the placenta, which is responsible for exchange of gases between the fetal blood and the mother's blood. Before we learn about the actual fetal circulation, we have to know about the following structures, namely foramen oval, ductus arteriosus, ductus venosus, umbilical artery and the umbilical vein. So what are these structures? So the foramen oval, which is the intra-arterial septum, which is present between the right and the left atrium. Ductus arteriosus, which is the normal fetal artery that connects the aorta and pulmonary artery. Ductus venosus, which is a fetal vessel that connects the umbilical vein to the inferior vena cava. Umbilical vein that carries the oxygenated blood from the placenta. And the umbilical artery, which carries the deoxygenated blood of the fetus. Don't confuse about the artery and the vein, because the second definition of the artery is that it carries the blood away from the heart, and the vein which carries the blood to the heart. I hope you understand about these structures. Now you can easily understand our fetal circulation. So this is diagram about our foramen oval, which is present in fetus, not in the adults, and the ductus arteriosus, which is a vessel that connects the pulmonary artery and our aorta. As you can see, the ductus venosus and the descending aorta and inferior vena cava, etc. Now let's learn about the fetal circulation. So from the placenta, umbilical veins that collect the blood which has more oxygen and the nutrients. The umbilical vein passes through the liver and some amount of blood is supplied to the liver. Liver also receives the blood from the portal vein also. Now, the large quantity of blood is diverted from umbilical vein into the inferior vena cava through the ductus venosus and enter into the right atrium. Here the blood is diverted directly into the left atrium through the opening of the foramen ovale and then into the left ventricle. And it is directly pumped out into the aorta. Here's the first mechanism. Now, the some amount of blood is from the upper body is carried out by the superior vena. Here, the blood enters into the right atrium. Here I want to clear that there is a deoxygenated blood of the fetus which is mixes with the oxygenated blood into the right atrium. And from the right atrium it enters into the right ventricle. Then into the pulmonary artery. As the lungs have high resistance, so the only small amount of blood goes into the lungs and provide the nutrition. And most of the amount of blood is diverted directly into the aorta to the ductus arteriosus. So this is up to the entrance of blood into the aorta. So what next? Means this is about how oxygenated blood travels into the body. But what happens with the deoxygenated blood? How can it go for oxygenation into placenta again? So here the blood travels from the ascending aorta to the arch of the aorta into the descending aorta. Then the descending aorta is divided into the common iliac artery. These common iliac arteries are divided into external and the internal iliac arteries. And at the last, from the two internal iliac arteries, two umbilical arteries are arises, which is passes through the umbilical cord into the placenta for oxygenation. So this is how a cycle which starts from oxygenated blood travels from the umbilical vein into the heart. Then all deoxygenated blood through the umbilical artery enters into the placenta for oxygenation. And here's the cycle repeats. As you can see, this is the actual circulation of the fetus. I hope you understand and I wish no confusion is there. So this is all about the fetal circulation and about its structure. So what happens after birth? Is that structure still present or not? So here is our answer. So when the fetus is delivered and the umbilical cord is cut and tied, the lungs start functioning. Because of the sudden hypoxia and the hypercapnia, respiratory centers stimulated and the respiration starts. As in the fetus, the lungs is a fluid-filled cavity. After the birth, due to expansion of the airway and the alveolar fluids is reduced and the air takes place. So the resistance is reduced and which allows the entry of blood into the lungs. Now the other structures which are the umbilical vein which forms the ligamentum teres, then the ductus venosus forms the ligamentum venosum and the arteriosus forms the ligamentum arteriosum. The umbilical arteries form the medial umbilical ligaments. And the foramen ovale after the few days after the birth completely closes and the fuses with the atrial wall. I hope you understand. Now you can easily understand about our topic, which is the Tetralogy of Fallot. So the Tetralogy of Fallot is the most common cyanotic congenital heart disease in all age groups, constituting approximately 8% of congenital heart disease overall. As the name suggests, tetralogy means 4 conditions are present. So which are these conditions? So they are ventricular septal defect, right ventricular hypertrophy, pulmonary valve stenosis, overriding of aorta, means there is a biventricular connection of aortic. One interesting point I want to tell that if the atrial septal defect along with the tetralogy of Fallot is present, it is known as the FETALogy of Fallot. Now let's learn about the pathophysiology. So as we learn about after birth, our structures of heart, means foramen ovale, ductus arteriosus, ductus venosus, turn into other structures. But in this condition, some abnormalities are seen, which in turn disrupt the circulation of our heart. So as you can see in this image, normal anatomy of the blood flow of the heart to the found in the Tetralogy of Fallot. Means there is a abnormalities which are the overriding of aorta, right ventricular hypertrophy, PSD and the pulmonary stenosis. So what really happens in this condition? So there is an initial defect is the narrowing of the right ventricular outflow tract into the pulmonary artery. Then this prevents the deoxygenated blood from the entering the pulmonary circuit, and the myocardium of the right ventricle hypertrophies in order to contract forcefully enough to push the blood past to the stenosis. So there is a large ventricular septal defect which allows the shunting of blood between the ventricles. So in a patients who have only ventricular septal defect, the blood is shunted initially from left to right. But in the Tetralogy of Fallot, as there is also ventricular outflow obstruction, it may impede the normal blood flow. So significantly left side of the heart becomes the path of least resistance. So the blood from the right ventricle is then forced into the left ventricle, creating a right to left shunt and the subsequent sinuses. Finally, the aorta overrides the ventricular septal defect and straddling the ventricular septal defect. So this allows deoxygenated blood shunted from right ventricle to immediately exit the heart mixed with the blood from the left ventricle. I hope you understand. Now, the most common, most important determinant of the severity and clinical consequences of the Tetralogy of Fallot is the degree of right ventricular outflow obstruction. So, with a lesser obstruction, blood is shunted from left to right and permitted to preferentially enter the pulmonary circulation, allowing for oxygenation. But if a greater degree of obstruction, however, blood is forced in the opposite direction away from the pulmonary circulation, leftward across the ventricular septal defect, and ultimately blood exits the heart before being oxygenated. So the patients will present with different degree of outflow obstruction, and this may fluctuate throughout the course of the illness. Now let's talk about the clinical features. So the timing and features of presentation depend on the degree of right ventricular outflow obstruction. So the patient with more severe obstruction will present earlier due to cyanosis. So this may be early as the immediate newborn period. Patients with the mild disease with so-called pink tetralogy, due to lack of cyanosis, their presentation may consist sign and symptoms of congestive heart failure due to the left to right shunting across the ventricular septal defect and subsequent pulmonary overcirculation. So ultimately, most patients with the mild disease will become cyanotic as the degree of outflow obstruction increases over time, as we talked earlier. So, as per the above, depending upon the severity, some children at the birth and early neonatal period are generally asymptomatic except for the presence of cyanosis. Within a few weeks to months of birth, children often develop dyspnea, fatigue, and hypoxic cyanosis spells and exertion, deepening of the cyanosis with a possible syncope. So, the dead spells are the hypercyanotic episodes precipitated by a sudden increase in right to left shunting of blood. They can be elicited by activity like feeding or crying, or they can occur without work. The classic description is of a patient who becomes cyanotic and then assumes a squatting position to relieve the cyanosis and hypoxia. Because squatting serves to increase the peripheral vascular resistance, thereby increasing the pressure in the left heart and subsequent forcing blood back into the pulmonary circulation. So it helps to relieve its dyspnea. Then the examination shows also the clubbing, central cyanosis, parasternal heave, systolic thrill, single loud second heart sound, and ejection systolic murmur in the second and the third left intercostal spaces. It is occurred due to the pulmonary outflow obstruction. The intensity and duration of murmur is inversely proportional to the severity of right ventricular outflow tract obstruction. Since ventricular septal defect is a large, so its murmur is not heard. As you can see in this image, the children with the TOF exhibits bluish skin during the episodes of crying or feeding, which is known as the TED spells. Now let's talk about the investigations. So first is chest X-ray. So the chest X-ray shows a large right ventricle and the small pulmonary artery. We can see the boot-shaped heart. So the boot-shaped heart is by the enlarged right ventricle and the concavity by the underdeveloped right ventricular outflow tract in the main pulmonary artery. As you can see in this image, the boot-shaped heart. There is a globular or ovoid appearance of the heart with the apparent narrowing of the superior mediastinum. We can also say in other words like egg on a string side. I hope you understand. Now let's talk about other investigations. So in the ECG we can say that the right ventricular hypertrophy is there present. Echocardiography is also useful, and sometimes cardiac catheterization is rarely needed as the echocardiography is highly sensitive. Now let's talk about the complications. So in the complication we can see the intravascular thrombosis, which is occurred due to the polycythemia resulting in a cerebrovascular accidents and the embolism. We can also see complication like brain abscesses, higher incidence of pulmonary tuberculosis and infective endocarditis. The other associated abnormalities also we can see. So approximately 40% of patients with the Tetralogy of Fallot have congenital heart defects. These heart defects include frank pulmonary stenosis, right aortic arch, abnormalities of the coronary arteries, patent ductus arteriosus or other defects. Additionally, clinicians should recall that the Tetralogy of Fallot is also associated with a number of genetic syndromes. So this genetic syndrome includes trisomy 21, which is the Down syndrome, Dalger syndrome, velocardiofacial syndrome. Now let's talk about the treatment options. Like what can be the treatment options to relieve the symptoms of Tetralogy of Fallot or to correct the abnormality. So once the TOF is diagnosed, almost all patients undergo corrective surgical repair within the first year of life. The treatment of hypercyanotic spell is directed towards improving pulmonary blood flow. So those include oxygen, knee to chest position, we can say the squatting position, morphine, IV fluids and the beta blockers. Once an infant has developed progressive cyanosis or has evidence of hypercyanotic spells or TED spells, surgical correction is indicated. So what can be the surgical procedures? So those include Blalock tossing shunt. So in the Blalock tossing shunt, it is a shunt which is created between the aorta and the pulmonary artery using the subclavian artery. It is a palliative surgery and not applicable for intracardiac repair. So we can say it is a not a curative surgery. The second option is a intracardiac repair. So it is a definitive repair. This consists of a patch closure of the VSD and the end enlargement of the right ventricular outflow tract with relief of all sources of obstruction. In some cases, the pulmonary valve need to be removed to eliminate the obstruction. So there are two surgical procedures, we can say Bellop-Toss insert and the intracardiac deflect. You can see the picture of Bellop-Toss insert, which is creates between the pulmonary artery and the aorta using the subclavian artery. Now let's talk about how physiotherapy can help to treat this condition. So the physiotherapy management include, so the patient with the Tetralogy of Fallot can live a relatively normal life and grow to adulthood after the surgical repair in childhood. Many studies have reported that in patients with the corrected POF, their exercise capacity, blood vessel, and the cardiac autonomic nerve function are still damaged and their health-related quality of life may be reduced. So the residual cardiopulmonary disease, sedentary lifestyle, avoidance of physical activity lifestyle are thought to be responsible for these differences. So the exercise training can be expected to offset these damages. So what can be our goals? So the goals of our treatment include patient and parent education. It is the most important part of our treatment because the pre-operative and the post-operative parent and patient education helps to decrease the complication. Now the second is mobilize the secretions, improve ventilation and improve the general mobility. So what can we do to mobilize the secretions? So there is a postural drainage techniques, percussion and vibrations are help to mobilize the secretions and improve the ventilation. So in some cases, if the child cannot tolerate this, place the child in a sideline position and rocking him back and forth. So it stimulates the expansion, secretion and relaxation. The second is how to improve ventilation. So there is a segmental expansion techniques, incentive spirometry. As an alternative way, we can use the balloons, as we can ask the child to inflate the balloons, as it helps to improve the expiration and inspiration. The third is improve the general mobility. So there is a range of motion exercises initiated as soon as possible because it may be beneficial for the child. Then the ambulation is started as soon as possible because it helps to decrease the pulmonary and circulatory complications. So this is all about Tetralogy of Fallot. I tried to cover most of the points and hope you like the video and find it worth. I already made a video on this topic, so you can get a brief idea about it. I will put the link in the description so you can watch it. Lastly, subscribe to my channel and hit the like button and share it with your friends. Thank you for watching. Stay safe, stay healthy. Bye.